Excuse me, ladies and gentlemen. Thank you for your patience in holding. We now have your presenters in conference. Please be aware that each of your lines is in a listen-only mode. You may submit your questions electronically anytime by using the chat pod located to the right of your webinar platform. You may also download a copy of today's presentation using the Files pod located directly below the presentation. It is my pleasure to introduce today's webinar, sponsored by Magnolia Medical Technologies, the national movement to a new blood culture contamination benchmark of 1%. Are you ready? Today, our first presenter is Gary Dorn. Please go ahead.
Thank you, Katie. My name is Gary Dorn, currently Professor Emeritus in the Department of Pathology at the University of Iowa. Briefly, I have a 35-year experience as the director of a clinical microbiology laboratory in an academic medical center, first at the University of Massachusetts Medical Center in Worcester, and then at the University of Iowa Carver College of Medicine. In my role as the director of the clinical microbiology laboratory in an academic medical center, I have seen firsthand the importance of adequate blood culture technology in the diagnosis of sepsis syndrome. And that's really the focus of our discussion this afternoon. How can the laboratory do better with respect to its role in the diagnosis of sepsis? Importantly, taking into consideration a primary factor, namely the issue of blood culture contamination. I'm joined in this adventure by Barbara DeBon. She's the Improvement Advisor for Cynosure Health and the former Director of Patient Safety and Infection Control at the California Pacific Medical Center in San Francisco. Barbara DeBon is without question a primary authority in the area of hospital infection control and antibiotic stewardship and is perfectly positioned to provide us with her insight from a clinical perspective about this all-important consideration of blood culture contamination. Specifically this afternoon, we're going to attempt to address the scope and magnitude of this problem. We're going to talk about its clinical implications. We're going to talk about the economic downside of blood culture contamination. And then we're going to talk about traditional methods that have been used to mitigate this issue, and then proceed on to a discussion of a relatively new technology, initial specimen diversion devices, as a means for reducing blood culture contaminations to very low levels and, in some circumstances, eliminating contamination altogether. Finally, what we're going to share with you is some real-life data in terms of the utility of initial specimen diversion devices as a means of reducing the problems of blood culture contamination. I'm going to begin by first talking about the reason we're here in the first place, bacterial sepsis. Bacterial sepsis is currently the #1 cause of hospital death and readmissions in U.S. hospitals nationally. Sepsis occurs when bacteria enter the bloodstream from a primary focal infection anywhere, leading in turn to a condition called bacteremia. The bloodstream is normally sterile, and when you find bacteria in the bloodstream, that can and often does lead to sepsis syndrome. Turns out focal infections can occur anywhere, leading to secondary bacteremia: the lungs, the liver, the abdomen, skin and skin structures, bone and joints, the central nervous system. Essentially, any primary infection that escapes the ability of local host defenses to contain the infection at its site can and potentially then does lead to bacteremia, which is an abnormal state. The blood is normally sterile. And the presence of bacteremia can and often does lead to sepsis syndrome. What's that? It's a life-threatening infectious disease problem, characterized typically by high fevers, hypotension, multi-organ system failure. It occurs frequently in the United States. Last year, estimated 1.73 million cases, and it has a significant mortality of between 16 and 17%. In turn, leading to over 270,000 deaths in the U.S. It's estimated that between 30 and 50% of hospital deaths are directly related to sepsis. This is a big problem. The diagnosis of sepsis rests with the performance of blood cultures. In this slide, we depict the process whereby blood is first collected from patients suspected of having bacteremia and then analyzed in a laboratory for the presence or absence of bacteremia. Blood is collected either by traditional venipuncture draw or perhaps by aspirating blood off of indwelling vascular catheters. That blood is introduced into blood culture bottles, which then go to the laboratory where they're processed. I'm going to spare you the gruesome details of this, but in general, a positive blood culture is detected within 16 to 48 hours after the specimen arrives in the laboratory. Now, importantly, once the blood culture is positive, it's important for the laboratory to identify the specific cause of bacteremia. Why is that important? Well, there's 1,400 different microorganisms that have been recognized as causes of bacteremia, and the management of those can vary based on the name of the organism. Furthermore, the antibiotic susceptibility profile of the infecting pathogen is important. In all of that, the identification of the organism and susceptibility tests then performed in a laboratory, that information is transferred to physicians responsible for the care of patients with sepsis, and therapy can be optimized. Unfortunately, it's not that simple for the reasons I show you here. On the upper left-hand panel on this projection is a 1000x magnification of your skin. On the surface of the skin, there's a layer called keratin, and what you see here is the fact that in a normal state of health, the keratinized layer of skin has a normal resident microflora, commensal bacteria. They contribute to a state of health. The bottom left-hand panel, that's 10,000 magnification. You can see those bacteria more clearly. And all of us have that resident microflora. And if you want to prove that to yourself, what you'll do is you'll take your hand and you'll place it on the surface of a Petri dish and leave it there for maybe 3 seconds. Then you'll take that Petri dish, put it in an incubator, and come back and look at it the next morning. And on the right-hand side of this slide, that's what you'll see. The resident bacterial microflora of your hand. It'd be the same thing if you'd sampled your elbow, your knee, your feet, your nose. We have a resident microflora, and that's there in a state of health. The problem, of course, is the methods that are used to collect blood for culture require introducing, in most cases, a needle through the skin, and so as a potential, the specimen itself gets contaminated. How often does that occur? Well, roughly 40 million blood cultures performed annually in the United States. At least, overall, 3% are contaminated. And in fact, in some institutions and in some care settings, contamination rates are way higher than 3%. If you then do some arithmetic, what that tells us is that annually in the United States, at least 1.4 million blood culture events are recognized, and there is an enormous price to be paid for that, estimated currently at levels of as much as $6 billion. The consequences of contaminated blood cultures apply both to the laboratory and, frankly, way more importantly, to patient care as well. I've been the director of a clinical microbiology laboratory, so I know a little bit about the impacts of contaminated blood cultures on laboratories, and I'm going to speak to that. But I'm going to suggest way more importantly than that are the consequences of contaminated blood cultures to the care of patients. And I'm going to turn this over in a minute to my colleague, Barb DeBon, who's going to talk to us about that. But first, what does it mean to the laboratory? It affects workflow, leading to the performance of substantial numbers of unnecessary tests, negatively impacts process productivity and performance. It's a major contributor to overtime, and not insignificantly, if you do the arithmetic, it leads to significant increases in costs, all of which are avoidable. That's what contamination of blood cultures mean in the laboratory. The real question, however, I would suggest is what does it mean clinically? But before we go there, I want to give you some idea of the scope and magnitude of this problem. We've already said that on estimate, 40 million blood cultures are performed every year in the U.S. We've said that at a contamination rate of 3%, there are a huge number of contaminated blood cultures totally and a lot of avoidable costs. What if using a new technology, heaven forbid that we think about using a new technology. This is, after all, the era of new technology. And we could reduce contamination rates by an order of 300%. We're going to change contamination rates from 3% to 1%. What do you get? Well, you get substantially less contaminated blood cultures, substantially less cost excess in the healthcare system, and as a consequence of that, presumably in the first place, better outcomes, and secondly, without question, substantial cost savings. And here's the rub. If you think about it, generally speaking, in standards of clinical practice, between 8 and 10% of blood cultures that are performed are positive. That, however, does not mean that 8 to 10% of patients suspected of having sepsis and as a result get blood cultured have a significant positive isolate. Remember, contamination rates are between 3 and 5%. Well, when you do the arithmetic, what that means is that 40% of all blood cultures that are performed are falsely positive because they're contaminated. That's a preventable error that has a huge number of downstream impacts. And again, some of those represent the basis for the information that we're going to share with you now. I'd like to turn this now over to my colleague Barb DeBon, who's going to talk about what I think is the most significant piece of this puzzle. What does it mean to patients that are seeking care in hospitals? Barb?
Thanks, Dr. Dorn. And this has been a very sobering opening, and I think it's really important that we recognize that that we have a problem. That we've been relying on a test, a blood culture test, that is so bad that we have to do it twice. And I don't know of any other tests in the lab that we have to do repeatedly because we don't trust the results. So I think it's a really important, I really appreciate the way that you laid this out and your ability to just really get our attention. So let's get to what this really, really matters. Why are we even having this conversation? We know that when a patient is diagnosed with a false positive blood culture, they're going to get antibiotics. We know that when a patient's laboratory result is interpreted as positive, they're going to get antibiotics that they possibly don't need. We know that antibiotics lead to antibiotic resistance. We know that it's a primary driver of C. difficile infection. We know that the antibiotics are not kind to our kidneys and can cause acute kidney damage and injury. We also know that it extends a patient's length of stay. And we know that the longer a patient's in the hospital, the greater the opportunity that something else might not go well, that they might develop some other kind of an infection or healthcare-associated infection or healthcare-associated condition. And we also know that right now, especially with what our country is facing with regards to COVID admissions, is we need our beds. We need our beds for patients that are sick, not for people that have had a false positive blood culture and are getting treated for something that they don't need to be treated for. And then finally, is if a patient does have a central line and they have a positive blood culture, they could potentially be diagnosed with a collapse that's not even real. And this obviously impacts the patient. The patient may have their line removed. They may need to have their line replaced. They're probably going to get really big gun antibiotics. And in addition to that, the hospitals who, as we know, we collect our data, we submit it to NHSN, and we know that there are at least 3 hospital-associated conditions, C. diff, MRSA, bloodstream infection, and CLABSI that are significantly impacted by blood culture contamination. We also know that COVID's impacted us profoundly, and we've seen an increase of CLABSIs in the last year in our hospitals. And then we have to also face the fact that we get financially hit. Hospitals are penalized for CLABSIs, and, it's bad enough getting penalized for a CLABSI that's real, but getting penalized financially for CLABSIs that aren't real is a real kick in the gut. So that's kind of a way to frame the impact that these events, these unfortunate and preventable events, have on our patients. So let's just take a pause for a moment, and I know that many of us that are on the call today are responsible for collecting and reporting blood culture contamination rates. They're on our dashboards. We have conversations with about this topic at our committee meetings. And quite frankly, traditionally, most have been okay with saying that, well, our blood culture contamination rate is less than 3%, so we're okay. Because traditionally, this has been the standard. This has been what we have been able to achieve at best because of all of the reasons that Dr. Dorn explained in terms of the problems associated with blood culture contamination. But as you're going to see as we go through this conversation together, there is nothing about 3% blood culture contamination rate that's good for a patient. And let me break this down a little bit because I think when we put this into numbers, it'll make a lot more sense. So what this means at a typical hospital, and this is only for hospitals in the emergency room. So this is a typical average-sized hospital in just the emergency room, which is where we know the majority of blood cultures are collected. We know that, say somewhere north of 800 blood cultures are collected, and if we factor in this 3% blood culture contamination rate, what this translates to is we have 25 patients from that one hospital. These are 25 people in our community, our neighbors, our friends, our loved ones, who are potentially impacted by a false positive blood culture every single month. So then when you do the math, you factor in the fact that if this is every month, by the end of the year, we have 300 people that have potentially been impacted because we have a test that is giving us results that aren't real. And then if you add in the dollars in terms of the amounts, this just under $4,000 cost per incident is actually a very conservative number. There are a couple of studies that were published in 2019 that had the average cost per incident of closer to $5,000, but let's just use $4,000 as an average. You can see there's a tremendous amount of money that is out there that is actually avoidable costs, over $1 million in just this one particular hospital. So what do we do about it? Well, Dr. Dorn did a beautiful job overviewing the impact of contaminated blood cultures to the clinical lab. And I'm going to add a bullet to Dr. Dorn's slide in that it impacts joy of work and sense of pride for our partners that work very hard in the microbiology lab to provide results that are valid and accurate. And I will say that I have seen way too many times that people are blamed. Phlebotomists are blamed, nurses are blamed, people are blamed for contaminated blood cultures. And why is that not okay? Well, let me just talk you through a couple of the reasons why training and education on best practices alone will not solve the problem. So let's start with just the process of a blood culture collection. Typically, there's a lot of hunting and gathering, scavenger hunt, collecting a bunch of stuff, having to put things together, many opportunities for touch contamination. So there's a lot of human factors associated with the problems where people have to collect a bunch of stuff and put it together. So that's one problem. The next problem, and Dr. Dorn showed you some very, very graphic photographs of all the stuff that grows on our skin. Our skin can never be sterilized. It can, at best, be cleaned, but we can never remove all of the bacteria from the level of the skin. And when we also think about what's underneath the skin, there's no way that no matter how well we disinfect the skin and no matter what kind of great technique we use, it doesn't impact all of the bugs that live underneath the skin layer. And then this is where it gets obviously very visual. Once we've cleaned the skin as best as we can, and we take a hollow bore needle and we poke it through the skin, and it goes underneath the skin layer to get into the vein to get the blood, all of the critters and crud that's living underneath the skin layer is now going into this hollow bore needle and then lands up in the blood culture bottle. So there's it's little wonder that we have contaminated blood cultures because of the process of having to get blood out of a vein by sticking it through skin that is heavily contaminated. So the most important message here is that despite all the great training and education and all the other things that we're doing, it doesn't solve the problem. So a real important message here is that it's not an arbitrary amount of blood that has been studied that's got the most amount of crud in it. It's the first 1.5 to 2 milliliters of blood where you have the most opportunity to pull away and not allow that amount of blood to go into the blood culture bottle, and that will, in essence, virtually eliminate blood culture contamination. So what other stuff do we do besides education and training? What other things do we do? Well, as a nurse, I know that I used to do this. I thought it was the right thing. We would do manual diversion. If we were doing a blood culture, we would try to draw some blood off into a red top tube and discard it. And we never really knew how much blood we were pulling. There was no way to really measure that adequately. But the important thing is that not only does manual diversion not improve the process, it's never been studied, it's never been shown to be a sustainable reduction in contamination. The best we've ever seen published is still a 2% contamination rate, which is still bad. And so the important thing about manual diversion, because we think it might be a good thing to do, is that there's no way to clean those tubes. They're full of nooks and crannies, and they can get contaminated so easily. And what can happen is if the inoculum needle gets contaminated, what will happen then is we'll have multiple bottles that will grow the same exact contamination organism, and then we will interpret this as a true bacteremia. So in essence, not only does it not make things better, but it potentially can make things worse. So again, the active diversion volume of 1.5 to 2 milliliters of blood in a system that's closed, so not manual diversion, but in a closed system, has been clinically shown to deliver up to 10 times greater reduction in blood culture contamination. So just to summarize, before I turn it back to Dr. Dorn, what we've been doing to date, it's just not enough. Training and education, very important, but it does not solve the problem. Adequate skin disinfection, very important, again, doesn't solve the problem. Some people say, well, we're just going to have dedicated phlebotomy teams. We're going to get a bunch of great people together with great technique, and they're going to fix the problem. Well, I'm going to share some studies in just a bit that will show, well, that doesn't work either. I just explained the manual diversion does not work. And then, of course, we do try to avoid drawing blood cultures directly from a central line because we know that there can be a lot of contamination in the hubs, and it's not an ideal practice. But despite doing all of these things, we're still not getting the improvements that we know that we can get as a standalone. So I'm going to turn it back to Dr. Dorn, who's going to walk us through this device and explain a little bit more about how technology can engineer out human factors.
So accepting the fact that we've got a problem and that traditional approaches to dealing with the problem, although helpful, don't get us to where we need to be, which is the avoidance of blood culture contamination altogether. About 10 years ago, Magnolia Medical Technologies embarked on this adventure to develop an alternative technique that does work. And what came from an enormous amount of effort is what I show you on this projection. This is a Steripath initial specimen diversion device. What happens is this. You can use it to collect blood by traditional venipuncture. You could as well use it to aspirate blood off of an indwelling vascular catheter, although with one exception that I'll get to in a minute, that's really not recommended. What happens is you collect the blood, and the initial 1.5 to 2 mLs of blood that passes through the catheter is then diverted. It's eliminated from culture. It's set aside, and that's what you see on the left-hand portion of this slide. There are at least two regulatory bodies that suggest that if you're going to do that, you've got to collect at least 1 ml of blood. With the initial specimen diversion device of Steripath, the volume of blood that's diverted is 1.5 to 2 mLs. And again, as you see on this cartoon, that's where the bacteria rest. And as Barb has told us, there's a reason for that. They're found in blood cultures in the initial aliquot of blood, not secondary aliquots. So you divert that aliquot of blood, and what do you do with the rest of it? You culture it. And as a result, the specimen that is passed then into the blood culture bottle is potentially free of contaminants. And I use that word carefully, potentially. We're going to find out if it works in just a minute by sharing with you some data from studies that have been done that have objectively assessed the utility of this device, but that's how it works. In fact, there's another modification of the device that allows it to be used on peripheral IV starts as well. So that's what Steripath initial specimen diversion device looks like and how it works. Importantly, it's the only FDA-approved initial specimen diversion device for use in reducing blood culture contamination rates. I'm going to repeat that. It's the only FDA-approved device with this indication. The question, of course, is we've got this lovely little device. It's easy to use, doesn't cost very much. Does it work? Well, Barb is going to talk about 3 studies that answer that question, and then I'm going to follow it by reviewing some additional data that, again, underscores the value of the initial specimen diversion device of Steripath as a tool for reducing blood culture contamination. Barb?
Thanks, Dr. Dorn. And I just wanted a couple of comments about the device that Dr. Dorn shared. One of the things as a nurse that I wanted to just underscore before I launch into some of these studies is that one of the features with the Steripath device is that it will not allow you to fill a blood culture bottle until you've actually diverted that optimal amount of blood into the special chamber. And as a nurse, and I can say this because I am a nurse, and I know that nurses, we're very efficient, and we try to get things done very quickly. It won't allow us to cut corners. It won't allow us to say, well, I'm in a hurry. I'm going to get this blood in the blood culture bottle, even though it's not there's not enough of a diversion volume yet. So that was one thing about the device I wanted to mention. And then I'm going to share a study in just a moment where this hospital utilized the device that is designed to draw blood from a freshly started IV, not an existing IV, but a freshly started IV. So I just wanted to make a couple of comments about that before I launch into some of these studies. Now, we don't have time to go through all the studies because there's so many of them, but I wanted to showcase that there currently to date are 6 peer-reviewed published studies that demonstrate not only the clinical advantages, but the cost effectiveness in terms of this technology. So we're going to travel a little bit around the country today. We're going to start in the middle. This first study took place in Nebraska, so we're right in the middle of our country. And I'm going to share a little bit about what Dr. Rupp and his colleagues did. So I mentioned earlier that dedicated phlebotomy teams have been a strategy for many hospitals to say, well, if we could just have dedicated phlebotomists, we could solve this problem. Well, after I share this data with you, you will be convinced that that actually is not the case. But what Dr. Rupp and his colleagues did is they designed this study. It was a single center study. But how they designed it was that they had phlebotomists who drew blood cultures from a patient, one from one arm using just regular technology, and one from the other arm using the same great practices, but adding the device that Dr. Dorn just reviewed with you, the Steripath device. So in essence, the patients served as their own controls. So you had the same phlebotomist drawing blood from a patient, one from one arm and one from another arm. So just to put this in perspective, before the intervention, the hospital's blood culture contamination rate was sitting at about 2.6%, which, you might be thinking, well, that's fine. It's less than 3%. But I hope that Dr. Dorn and I hope that we have convinced you that 3% is absolutely not acceptable. So that was their baseline. They started at 2.6%. So then what they did is in a 12-month period of time, they had one blood culture on one arm using phlebotomy best practices, and then another blood culture from the other arm using the best practices in addition to the Steripath technology. And as you can see from this slide, they experienced a significant reduction in the arm that used the technology, at 0.2%, which is pretty darn close to zero. So you can see that not only did they achieve a dramatic reduction, again, this is the same patient's skin, same patient's flora, nothing different about technique except the use of the device. And then equally importantly is that it didn't negatively impact the positive predictive value, because you could think, well, gee, what if somebody really does have a bloodstream infection and we're not going to get it? Well, that wasn't the case either. So you're thinking, well, this is pretty impressive. Well, hang on, because it's about to get even more impressive. So what they decided to do after they experienced this sustainable improvement and reduction in blood culture contamination is they said, well, let's see what would happen if we stopped using the device. We're going to have the same procedures, the same technique, but we're going to take the device away. And as you can see on this slide, their blood culture contamination rate went even higher than it was at baseline. It went up to 2.8% as compared to 2.6% before the intervention period. So to me, there's no better way to dramatically prove that it really wasn't about the great people. I'm sure they are great people, but it wasn't about people and technique. It was about technology. And so this is a profound demonstration in Dr. Rupp's study that demonstrates not only did it improve patient care, but it was potentially a major cost saver. And let's be frank, that's an important thing for those of us that have limited capital, that we are always being challenged and asked, well, how much does something cost versus how much is something going to save us? And the dollar savings here is significant. All right, so that was a study that was done with phlebotomists in the middle of the country. Now we are on the East Coast. We're down in Florida, and this was a study that was done at Lee Health, specifically in the emergency department. And a couple things about this study that are really worth noting. One is that this was four different centers, 4 different hospitals, which is important because sometimes we know that, well, we might get a certain outcome in one particular setting. Are we going to see the same things across centers? And they did. So what this group did is they specifically studied blood culture contamination rates, and as you can see, the majority of their venipunctures were on freshly started IVs. So these were patients that were coming into the ED that needed an IV started, that needed blood cultures drawn because the patient was obviously presumed or suspected to be septic. And what the nurses were able to do was to start the IVs, most likely 2 peripheral IVs, and draw the blood cultures directly from the freshly started IVs. So not only did they dramatically reduce their blood culture contamination rates, as you can see, but they also avoided having to stick the patient 2 more times, because sometimes, as we know, and it could go either way. There are some hospitals that even without this technology, the nurses are sometimes tempted to draw blood culture from a freshly started IV. We know that happens. Or there are other hospitals where they start the 2 IVs, and then they also draw 2 peripheral blood cultures. So the patient's getting stuck 4 times. Not a good thing for patient care, not a good thing for needle stick exposure. It's really not a good thing for anybody. But this study that Bell and colleagues produced in Lee Health in Florida demonstrated a significant, an 83% reduction in contamination. And again, the important thing to see here is that the majority of their Steripath draws are fresh IV, peripheral IV starts, which is the significant learning experience here, and demonstrated a significant reduction in cost. And Dr. Dorn, in just a little bit, is going to go through kind of an overview of the studies, but it's important to know that there's a total of 11 studies, 3 of which are peer-reviewed and published, but there's a total of 11 studies that have looked at peripheral IV blood culture draws. So this wasn't a one-off. This has been reproduced, and you'll see that in just a little bit when I finish this next study. All right, so we've been to Nebraska, we've been to Florida. Now we're back to the left coast, and we're in California. I had the pleasure of facilitating a different webinar with Dr. Lucy Tompkins last week, and this piece of work is really profound. Dr. Lucy Tompkins has been a champion for reducing blood culture contamination for as long as I've known her, and it's been decades since this has been one of her primary areas of focus. And what drove them at Stanford Health was that they were highly disturbed by the fact that they knew that they were reporting CLABSIs that were not real. They knew that they were identifying patients that met the NHSN definition for CLABSI, but that it was a contaminated specimen. So that was part of their driving forces, but they also recognized that they knew that patients were being identified as having false positive blood cultures and were receiving antibiotics they didn't need, and all of the other harms that result from unnecessary antibiotics. So what they did is this was a hospital-wide study, so not just in the ED, so a little bit different from Dr. Rupp's study, and it was done by the phlebotomy team. And what they were able to demonstrate was a profound reduction in blood culture contamination, 100% reduction. They got themselves down to zero contamination rate. And to date, they've done over 14,000 cultures. So this is a huge, huge study. And then to underscore the importance is that they've virtually eliminated their false positive CLABSIs by utilizing this technology. And that's a win for everybody. It's a win for the hospital. It's a win for the hospital's reputation and their publicly reported data and their financial penalties. But most of all, it's a win for the patients. And then a real important distinction is their standardized infection ratio fell dramatically, but between 30 and 50% when the contaminants were removed. So we know that Dr. Tompkins is working on her manuscript, probably as we speak, because I don't think she ever sleeps. And I know for a fact that when this study comes out, it's going to profoundly impact and drive practices. So that was my attempt to just share 3 studies in different settings to demonstrate the impact and the efficacy of the technology that Dr. Dorn so beautifully described. So I'm going to turn it back to you and have you kind of run through an overview of the studies to date and just pick out a couple things that you think are noteworthy.
Thanks, Barb. What Barb has just done is a deep dive into 3 published studies that have examined systematically the utility of the Steripath initial specimen diversion device as a means for limiting blood culture contamination, and it works. There's a lot of other studies that have been done as well, 19 total. They're depicted for you here in this almost unreadable slide. I promise you, I'm not going to wander through each of these individually. What I'm going to do is provide you with some highlights. The first is to draw your attention to the rates of contamination that were obtained in these studies. By the way, 6 of them in the peer-reviewed literature, all of the others presented at national medical scientific meetings, and in every case, contamination rates of less than 1%. And in a couple of cases, the elimination of contamination altogether. In the blue boxes, what you see is the percent reduction in blood culture contamination as a consequence of using the Steripath device. Importantly, when I see data like this, I ask the question, what about the patient populations? Well, you can't do 19 studies without covering the waterfront. This is literally more than 100,000 blood culture events that have been assessed with the Steripath device. So it's compelling information. I would also draw your attention to the data that you see at the bottom, because a couple of these studies tried to do some arithmetic in terms of avoidance of hospitalization and cost as a consequence of a false positive blood culture. And what you see is, on the average, 2 bed days were eliminated by avoiding blood culture contamination, and it was estimated that the cost savings for that was close to $4,500. So significant savings both in terms of utilization of hospital resources and in terms of cost. I would also make the point that nowhere on this slide do you see any evidence of a study that has compared the Steripath initial specimen device with the Curin initial specimen device. And the only reason I raise that is because we have access to some questions that are being asked by people that have tuned into this webinar. And Gary Breckenridge has asked the question, what about the Curin device? It's a good question, Gary. It allows me to say this. Number one, that device only collects approximately a half a cc of blood for diversion, and we absolutely know now that that's an inadequate amount of the volume of blood to avoid contamination. We've already determined that to be between 1.5 to 2 mLs of blood. So inadequate collection of blood for diversion. And secondly, and importantly, this is the day and age of evidence-based clinical practice. To my knowledge, there are 2 published studies in the literature that have assessed the Curin device as a means of avoiding blood culture contamination. Now, admittedly, both of these studies appeared in peer-reviewed journals, but I hadn't heard of either one of them. When I bothered to actually read the studies, I can tell you that they were grossly underpowered. We clearly need information from a systematic, broad-based, objective study assessing the Curin device. We have 19 such studies with the Steripath device. I'm still looking for the first meaningful published study with Curin. So at this point, in view of the fact that there is essentially no data, and furthermore, objectively, we might imagine that this device is going to be limited because of the small volume of blood that's collected, I don't think objectively we can give any consideration whatsoever to using that device as a means of avoiding blood culture contamination. What we're left with is one device, and as you see here, it works. And it's important that we understand that it works extraordinarily well in the context of where we seem to be going with regard to a new standard for blood culture contamination in the U.S. Both Barb and I have said that there has, until fairly recently, been a general acceptance of a 3% rate of contamination. That's allowable. I don't know how we could ever consider any contamination allowable, but at least in terms of laboratory standards, 3%, well, we are moving in the direction of an actual standard of way less than that, less than 1%. And part of the reason for that is shown you on this slide that I just presented. It's doable. Again, if we look at the green section of this slide, you see that in every single case with this initial specimen diversion device from Magnolia, contamination rates of 1% or less are easily achievable. So, as a result, myself and a few other people, forget about me. 3 of the people depicted on this slide, Mel Weinstein, Dan Diekema, Karen Carroll, and my good friend and colleague Dan Sexton, are true authorities in the fields of infection control, infection prevention, antibiotic stewardship, and laboratory medicine. And we came together about 2 years ago and created a review that was published in Clinical Microbiology Reviews. It basically summarized for you everything that Barb and I has been talking about. Don't know if any of you suffer from insomnia, but if you do, get this review and read it. It will take care of your insomnia. And then when you wake up, you'll know everything there is to know about blood culture contamination and a new benchmark in terms of allowable contamination rates. And what is that? Less than 1%. Barb has introduced you to Dr. Tompkins from Stanford. She's been talking about this issue for a good long period of time, and given the nature and the results of her recent study, a truly compelling study, this is doable. And finally, we are moving in the direction of this actually having some traction in terms of regulatory entities. Now, many of you are familiar with the Clinical and Laboratory Standards Institute. This is an organization that drives standards of laboratory practice. And when the CLSI mandates a standard, it's only a matter of time until clinical laboratories and then the institutions in which they're found fall into line. Clinical and Laboratory Standards Institute and their Committee on Blood Culture Practices has recently decided that 3% is no longer acceptable, that a target contamination rate of at least 1% is achievable. Now, this standard currently exists in a proposed draft. It'll be in that form for about 6 months, during which time practitioners are allowed to make comment. Those comments are taken into consideration. And finally, a formal approved version of this standard will appear probably early in 2022. And what that means is the new standard is 1%, it's no longer 3%, and at that point, we all need to begin to pay attention. I'm going to suggest, however, that notwithstanding what the CLSI is doing, and for that matter, the fact that the Department of Veteran Affairs has picked up on this and is moving in exactly the same direction as you see here, that no contamination is acceptable. I suppose it's useful to have a standard that drives practice to a better place than we've been, and certainly 1% is going to do that. But I would make the point that in that 1 in 100, remember now 1% is allowable, and that 1 in 100 patients who has a contaminated blood culture, all of the implications that Barb and I have been talking about in the last 45 minutes are still applicable. So what about thinking about a procedure, a technique, an algorithm that allows us to eliminate blood culture contamination altogether? Well, the fact of it is there's only one device that gets us there. And now perhaps you can understand my obvious enthusiasm for the use of the Steripath initial specimen diversion device as an important tool for eliminating blood culture contamination. The downstream implications are enormous. On the front end, the ease of use, the relatively limited low cost of the device, absolutely recommends it. And with that, I'm going to turn this over to Barb to take us to conclusion of this webinar. Barb?
Thanks, Dr. Dorn. I think it's really, we just finished the Olympics. The Paralympics are going on right now, and what makes me, I think about how, we keep seeing people run faster and swim faster and do everything so much better than they used to, and when they do that, we change the benchmark. We move the finish line, and I feel like that's where we're at right now with this. As you mentioned, this is all about evidence-based studies, and it's so compelling to know that we can no longer sit back and be okay with a contamination rate that we know, when we know we can do so much better than we're doing, it's really irrefutable. So I'm feeling that we're going in the right direction, and I find as a clinician, as a nurse, as an infection preventionist, I find this to be just such a positive movement. So I wanted to just spend a moment here and just make sure that everyone on the line is aware that there are different configurations for Steripath, and the device on the left-hand side is what Dr. Dorn showed you with that was used by the phlebotomist. That's the device that also has, which is important to know, it has when there's a gentle squeeze placed on the device, what that does is it actually creates some negative pressure, and it's extremely useful, especially when we're trying to pull blood from somebody who's septic and obviously has a very low blood pressure. So it's a really important feature where the blood doesn't just have to, like roll out of the patient's vein. It's actually kind of coaxed out by this pressure that's applied. So that's the device on the left that Dr. Doran did a really nice job explaining. And then a couple of other features that I wanted to point out. There's also, it's important to note that there is a syringe draw, which I'm seeing a lot of comments in the chat box about this. What about my hard stick patients? What about the patients that are really hard to get blood out of? Well, there's a syringe draw technology, and that's exactly what this is designed for, are those patients that are very difficult to get a blood sample out with a vacutainer method. So it's a syringe design. And then the device on the right is being utilized in children's hospitals, and this is a smaller diversion, which has still been studied to be acceptable, but this is for our children's hospitals and is currently being studied, and hopefully we'll have more information about this soon. But it's really important to know that there are different approaches to taking blood culture from patients. And as a reminder, a good number, 11 of the studies that were shared with you were studies that were done on fresh IV starts. So again, when we have a device that not only virtually eliminates blood culture contamination, but is compatible with our workflow, that's a win, especially for clinicians that are working in incredibly hectic environments and under a tremendous amount of pressure. So the movement to 1% is, I find, to be a really encouraging thing. So what have we done? What have we done today? What have we discussed, and where do we go next? So when we think about how each and every one of us has the ability to impact achieving less than a 1% contamination rate, we've discussed that we know that the basics that we're doing, the good practice, the education, the training, we know that that's important, but we know that it's not solving the problem alone. We also know that manual diversion not only doesn't make things better, but it can actually make things worse, because it confounds the interpretation when potentially that inoculum needle gets contaminated and multiple bottles grow the same potential skin bug that's going to be interpreted as real. So we know that the things that we've been doing have been the best we've had, but now we know better. And once we know that we can do better, it's really up to us to continue this charge, or this adventure, as Dr. Doran likes to call it. And so just to kind of summarize what we've described today is that we know that if we can improve our sepsis testing accuracy, which is really all about impacting the patients, is that we're going to give a lot less antibiotics that are going to cause a lot less harm. We will impact our antibiotic pressure. We'll see hopefully less patients with resistant organisms, less patients with C. difficile or kidney damage from drug-related complications. I see this technology as an impact. It's a driver of antibiotic stewardship, because when we think about it, our laboratory stewardship and our diagnostic stewardship is what directly impacts antibiotic stewardship. And if we don't grow bugs that aren't real, patients aren't going to get treated for things they don't have. We also know that it's going to greatly reduce length of stay. And I mentioned earlier, never has that been more important in our country, where we've got stories of hospitals that literally don't have beds, even for their med-surg patients, because of our COVID pandemic just blowing up in so many parts of our country. So anything we can do to reduce the length of stay and a readmission is a good thing, reducing other kinds of harms from happening. And then a real important thing, and this was demonstrated in Dr. Lucy Tompkins' work at Stanford, is preventing false positive CLABSIs, not only because it can potentially harm the patient, but because a false positive CLABSI is going to be reported at NHSN. There's going to be associated financial penalties, and it's disheartening. It's disheartening to have to report something that we know isn't real. And then clearly, we've demonstrated through many of the studies that we've shared with you today is that there's a significant hospital cost savings. It's not just the patient reduction of harm, but it also impacts the patients, the hospitals, and their cost savings. So we have got. It looks like we've got a little bit of time for some questions, and we've got a ton of them. But before I launch into the first question, that I think I'm probably going to toss to Gary because it's a tough one, is if you have the need or desire for additional information, we wanted to make sure that you had the ability to reach out to clinicians and to those at Magnolia Medical. So the links and the phone numbers are listed on this slide, so feel free to do that. But I'm going to read the first question and see if Dr. Dorn wants to take a crack at this. It says, my hospital lab does not support drawing blood cultures from fresh peripheral IV starts. Do the Steripath studies report the same under 1% blood culture contamination rates via peripheral IV starts as they do via venipuncture? That question is for you, Dr. Dorn.
Yes. Next question.
Would you
the
like
answer to that is yes.
That? Okay, yes.
No, we've seen that to be the result from 3 studies, and yes, as long as it's fresh peripheral IV starts, Steripath works. So the answer is unequivocally yes.
Good. So you mentioned 3 peer-reviewed publications, but there's also there's a total of 11 studies, 3 of which have been published in a peer-reviewed journal. So it's not a one-off. And I know I'm going to pick on you as a laboratory as a microbiology expert, because I know that and I've worked with a lot of microbiologists and who really were just so against drawing blood from IVs. And is that because people were tempted to do them from existing IVs? Is that what the problem was?
Yeah, the problem, of course, is when you have an indwelling vascular catheter of any kind, a long line or an initial IV, the business end of that catheter gets colonized with the organisms that are on the organisms that are on the skin. And when you draw blood through that catheter, what you in effect are doing is surrogate sampling of the skin. So yeah, contamination of blood through indwelling vascular catheters of any sort, almost irrespective for how long they've been in place, has always been a bad thing because they get contaminated. Steripath gives us an opportunity to avoid that problem.
Thank you. And my understanding, too, is that the diversion volume, when we're doing peripheral IV starts, is even more critical. It's so important that we pull off that 1.5 to 2 milliliters of blood. So, again, using the technology gets us there. All right, moving on to another question. Do the presenters feel that CLSI will change the national benchmark from 3% to 1%? And if yes, at what point does the 1% target become a formal CLSI benchmark?
Maybe that's something that I can address, Barb. Having spent 12 years of my career on one of the CLSI subcommittees, I think I understand the process. The new M47 guidance document exists in a proposed state, so it's published, and it recommends that institutions seek a blood culture contamination rate of less than 1%, but whenever possible, eliminate contamination altogether. That document is going to exist in a proposed form for about 6 months, during which time practitioners get to comment on it. CLSI takes those comments into consideration and then publishes an approved document, an approved standard as it is, which is in all likelihood going to be available first quarter of next year. Now, just because CLSI makes a recommendation, that doesn't then necessarily have the effect of law. What then has to happen is for two other entities, the College of American Pathologists and the Joint Commission, to adopt that standard, but that happens as a matter of course. So in effect, when CLSI has an approved standard, it really is a driver of at least laboratory practice.
All righty. Well, I think that's a great note to end on. It looks like we are out of time. I'm getting a high sign, so I'm going to turn it back to our organizers to close us down.
Thank you, ladies and gentlemen. This concludes today's webinar. You may now log off and disconnect.